able to join. There you go. So anyone should be able to use this as a resource on the back end, and we'll find a good place to post it on our website. And the other housekeeping item is if you do have a question that you want addressed, we'll try and leave time at the end for it. Please throw that into the Q&A box. You should see the Q&A box on the bottom right-hand side of your screen. Dr. Jans will keep an eye on those and then moderate us through some Q&A at the end of the prepared marks. With that, let me turn it over to Dr. Jans.
Thank you, Dr. Cantor, and thanks to everyone who's able to join us during their lunch break today. This is meant to be somewhat of an informal and somewhat of a very interactive session. So hopefully this is pretty light lifting while you're eating your lunch today. And just to give you the 10,000-foot overview of what we're doing here, it all begins of where we started, and that's back in the spring of 2020, when we gave similar seminars for the Louisiana Department of Health. This group of presenters that's listed on your screen, we gave similar seminars back then in the spring of 2020, but for different reasons. Back then, we were giving seminars focused on COVID-19 because no one knew anything about it. It was brand new. Everyone was trying to figure this thing out, how to figure out how to take care of patients, outpatients, inpatients, patients in the intensive care unit. And we were just trying to grasp a hold of anything that seemed like it worked, and then try to teach people how to take care of it. So we go all the way back to spring of 2020, and we did similar seminars because we didn't know much about COVID-19. And now we fast forward today, and we are bringing back these seminars for the opposite problem, because now we know so much about COVID-19. COVID-19 therapeutics has become almost as complicated as chemotherapy. There's a whole litany of different drugs, interventions that have been tried. Things are published on almost a daily basis in regards to how you can treat a patient with COVID-19. And it's become pretty complex to keep up with all this stuff. And so we decided we should bring back these seminars for all of you, the participants in this, so that we can hopefully at the end of this provide you with some straightforward and simplified way of treating patients with COVID-19. That said, the documents that we're going to go through that have been developed by the other presenters during this meeting, those are also going to be available to you. So you'll see those documents in a minute. We'll provide those to you. Now to the presenters for this seminar today. Like Dr. Cantor said, I'm Dave Jans. I'm the Director of Medical Critical Care Services at UMC in New Orleans. Dr. Chris Thomas, who's an Assistant Professor of Medicine at the LSU School of Medicine, and is also the Medical Director of Quality and Patient Safety, along with Dr. Bud O'Neill, who's an Associate Professor of Medicine with the LSU School of Medicine, the Director of Research with Our Lady of the Lake. You'll see a lot of the materials that they and others with Franciscan Ministries have developed in regards to taking care of patients with COVID that hopefully make it simpler for you. And Dr. Amita Krishnan, who's an Assistant Professor of Medicine at the LSU School of Medicine, who's taken care of hundreds, possibly even thousands of COVID patients by this point, and also is the content expert for ethics and critical care for the American College of Chest Physicians. Like Dr. Cantor said, put questions in the Q&A section, and we'll monitor those questions. And we'll either answer those questions in real time or at the end of the entire seminar today, if there's time left. And with that, we're going to launch into our agenda here, which is outlined here. So first, we're going to have a discussion, brief discussion about the epidemiology of outpatient infections. Next, we're going to talk about treating specifically the outpatient with COVID-19. We're not going to talk much, if any, today about treating inpatients or ICU patients with COVID-19. That's going to be saved for next week. And then finally, we're going to talk about responding to requests for non-beneficial interventions. Not only has the treatment for COVID-19 become pretty complex with lots of information to know, but now the general public is all of a sudden interested in all these things, constantly researching all these things, and more frequently will they ask you for things that don't help a patient. And you need a toolkit to help respond to those requests when you get them, because they're becoming more and more common. And with that, we're going to, like I said, we're going to start a little bit with some vaccine effectiveness data, and we're going to turn it over here to Dr. Thomas.
Thanks, Dave, and thanks to the audience who is joining us today. Hopefully this will be something that's valuable for all of you. Any conversation here in the winter time, as we move into the fall and then the winter, has an idea of really where are we at current pace. A reference for us both last year and currently is flu. We're moving into the flu. And so I thought to center the group, these are slides that the Joint Commission provided last week, and looked at what the actual impact is of COVID in relationship to deaths, because as a patient shows up to your office, to your clinic, to the urgent care, the conversation about a patient-centered outcome is really important. So for references, this is Soldier Field in Chicago. We're Louisiana, it's a big football state. And what you can see is that average amount of patients and deaths in the United States for the last 10 years essentially is approximately 36,000 people, or 60% of Soldier Field. When you move to the conversation then from flu as a reference of what we all have from an outpatient perspective, and we move to the next slide and you talk about the opportunity as it relates to what does COVID look like with that same graphic. This is COVID for us, unfortunately, from the time Dr. Jans talked about it, 2020 to August 2021. And unfortunate that we've lost over 600,000 of our colleagues and friends and family. And really strikingly, it fills up 6 to 7, even before vaccination, of the Soldier Field. So that's the amount of people that we've lost. With initiation of the vaccine, what you can see is that black line where we still continue to have people that we've lost. And so what's the therapy? How do we prevent this? But more specifically, when you start to look at all of those deaths, you focus in to the end zone and start to look about the differences between vaccination objectively and those who are unvaccinated. If you then move a little bit more significantly and say on the next slide, well, how do I think about this? How do I have a conversation with the patient who shows up at my clinic before they get infected and we get to the therapeutics? What if the vaccinations really didn't work? Let's use equipoise. Let's have a conversation. So if there are 170 million people in the United States are vaccinated, and that leaves around 165 million unvaccinated, if you're 50-50 split, if a therapy has absolutely no impact, then what you should see is this graphic. And that the overall during the week of August 15th to 24th to 21st, you should see the amount of death to be equivalent in both vaccinated and unvaccinated. Unvaccinated in purple, vaccinated in the gold. But that's not what we've seen objectively in evidence-based data. And the next slide really shows you where we exist and where we are. So when the patient comes to your clinic and says, well, doc, what really is the possibility for me? What's it like in the initial therapy, the opportunity before I acquire the virus? What does the vaccine do? I thought this graphic was brilliant and put out well by the Joint Commission, that in this week, in the blue is essentially the unvaccinated deaths that we've experienced, and in the gold is the vaccinated. This is a graphic that you can show to your clinic patients as they present, and they have another conversation about you if they have vaccine hesitancy or have an opportunity to say, really, what do you recommend to me as best practice? So any conversation about outpatient COVID therapeutics should initiate and start with the conversation of vaccination, because it is the most evidence-based intervention to prevent hospitalization and death. And those are the patient-centered outcomes that our patients come to us in the clinic to ask us about. With that conversation, I'll move over to Dr. O'Neill, who's going to really give you a real-world view of what that looks like on a macro level to now a local level here in Baton Rouge. Dr. O'Neill?
Yeah, thanks, Chris. So one of the things that we look at, and if you're looking at the data, so this data is all derived from Our Lady of the Lake Regional Medical Center, the Baton Rouge market. This market, and this is looking at data from the emergency departments there. This market includes hospitals, Our Lady of the Lake Regional Medical Center, that's an 800-bed hospital in Baton Rouge. The Our Lady of the Lake Children's Hospital, which is across the street, which is a pediatric hospital. St. Elizabeth's Hospital, which is over in Gonzales, so really more of a of kind of a suburban and more rural type population, as well as a North Baton Rouge Emergency Department, which is in North Baton Rouge and is predominantly an African American community. So I think that looking at the Baton Rouge market for Our Lady of the Lake is a pretty decent biopsy of what's going on in Louisiana as a whole. And if you look at this, this starts at the beginning of the pandemic back in March of 2020, over on the left side. And so the light blue are unvaccinated ED patients, and the dark blue is unvaccinated admitted patients. So if you add it all together, those are the patients who presented to the emergency department, and the dark blue are the patients who were ultimately admitted from the emergency department. If you look early in the pandemic, in that first wave, that first spike, most of those patients were admitted. There's a lot of reason for this. One of which is that we just didn't have access to great testing. It took a day or two or three to get tests back. So we admitted a lot of people not knowing what they had or what to do with them. And then you see that kind of second spike, that second peak that we had in July of 2020. And then you see the winter spike that we had. And then you see this most recent Delta spike, which is just striking in the size that it is. And again, this is a single market in Louisiana, but you're looking at 700 cases or so a week, and you look at the number of admissions we have, and then over on the right hand side you can see the green line are the vaccinated patients who presented to the ED, and the orange are the vaccinated patients who are actually admitted to the hospital. And so it really gives you a good look at what happens in the outpatient setting. I know that the outpatients, the general clinic setting and the urgent care setting is somewhat different than the emergency department, but those data are very difficult to collate for us. So I think that looking at our emergency departments gives us a good look at how these patients behave and what percentage of them ultimately need to be admitted to the hospital. So we can go on to the next slide. And we can look, and this is by week. This is adult ED visits and admissions. Again, this is the Baton Rouge market, so similar data to what you saw previously, but now looking at adults only. And you can see that in our most recent surge, we were seeing 600 plus adults in a week in the emergency department. The minority of those patients were vaccinated patients, but this is ultimately what that looks like. And I should tell you this too. So this is data that we derive from our own emergency departments, and looking at this overall mortality of patients who walk into the emergency department. So if you walk into the emergency department with this disease, your overall mortality is going to be somewhere around 3%. Okay. If you seek ED care for COVID, the mortality is about 3%. If you're admitted to the hospital, again, this is our data from our hospitals. If you're admitted to the hospital, your mortality is 6%. If you're ultimately transferred to an ICU or admitted to the ICU, your overall mortality is between 20 and 25%. And if you were then intubated, your mortality is greater than 50%. So as you look at this, keep that in mind when you look at those admitted patients to the emergency department. Those are admitted patients to the emergency department that are admitted patients to the med-surg unit in the orange, and admitted to the critical care unit in green. You'll see that these patients, those patients who are admitted to the ICU, have about a 25% mortality, and those admitted to a med-surg unit have about a 6% mortality. So we can move on to the next slide, and you can see how this looks for the pediatric population. Again, the mortality is much less, thankfully, for pediatric patients, but if you look in a week, we were seeing 60, 70 patients in the emergency department at the children's hospital with COVID, and that's just a striking number of kids coming into the emergency department with this disease. And there were a significant number of admissions, both to the med-surg floor and to the critical care unit in this situation. And so people who tell you that this disease does not impact children are just wrong. Our data would tell you definitely otherwise. So we can move on to the next slide. And remembering those overall mortality data that I gave you, remember 3% in the emergency department, 6% admitted, 20% in the ICU, and then greater than 50% for intubated. If you look, this was from the LDH's dashboard this morning. If you look, there were 732,000 cases this morning when I looked at it. There were 13,657 deaths reported. That's an overall case fatality rate of about 1.87%. Now, we understand that there's difficulty with reporting in that, we probably underreport total cases. Some people are never tested, so they're not reported. Some people are tested. Now we have home antigens, and so those aren't reported. So that number, the total number of cases, is probably higher than that. I think it's a little easier to capture total deaths. But either way, you see that mortality rate of about 1.87%. Over on the right are data from Johns Hopkins looking at the United States in general, and you'll see the overall case fatality rate of COVID-19 is somewhere above 1.5, but less than 2%. So you can see that actually in Louisiana, we're just reflective of what's going on. That is just reflective of what's going on in the nation as a whole. And fortunately, in the United States, we're a little bit better than globally. But I don't know that you would call that a lot better. But overall, this is a deadly disease. COVID remains a deadly disease. And so I grew up in rural Southwest Louisiana, and my grandfather, when he was telling us something, and when he meant it, when he was being real, he would say, I'm serious as a heart attack. And so I started thinking, I was like, well, what does that mean? So the question is, how serious is COVID and how serious is a heart attack? So this is a study from early in the 2000s. This is the Cadillac study that actually looked at stenting ST elevation myocardial infarction. Okay. I think that most of us would consider a STEMI, an ST elevation myocardial infarction, to be one of the absolute true medical emergencies. And it is such a medical emergency that there's such a process around it that a patient with a STEMI who's diagnosed in the field can bypass the emergency department, go straight to the cath lab. This is something where EMS has the ability to mobilize an entire, basically team of physicians and nurses and highly skilled individuals to treat. The overall mortality in this study, 30-day mortality, was somewhere around 2 to 3%. So just think about that. If you walk into the emergency department with COVID, you have about the same mortality as coming into the emergency department with a STEMI. And that, to me, is just striking. And the 6-month mortality for STEMI in this study was about 3 to 4%. And so I looked at this and I said, well, this is a clinical trial. In clinical trials, we tend to do, we're on our A game, if you will. They have the best of the best doing these studies. And so they have a process set up that's a clinical trial. So I said, well, what's the real world data look like? And so you can go on to the next slide. And so these are data out of Australia. So this is the Australian Capital Territory, which is their kind of version of Washington, D.C. It's an area, kind of a small landlocked area around their capital. And this is a tertiary referral center where they have a registry, and they looked at about 1,300 consecutive patients with STEMI. And they found that their overall 30-day mortality, okay, so this is just real world data in a real world tertiary referral center, not a clinical trial, real world data, their overall 30-day mortality was about 4%. Their 1-year mortality was about 7%. So when you look at that, I could tell you that without a doubt. And so when my patients ask me, or they say something like, this COVID thing isn't that bad, it's only killing certain people, I tell them, well, it's as serious as a heart attack. In fact, it's as serious as an ST elevation myocardial infarction, for which we have, tremendous process set up in the United States. And I guess if I were to ask those patients, would you take your chances with an ST elevation MI? Would you take your chances with a heart attack? Those patients are going to tell you, well, no. And if I told them, well, there's a single injection that can do a couple of things. Number one, reduce your risk of ever having that heart attack. Number two, if you do have that heart attack, you reduce your risk of death from it. And number three, this is a special kind of heart attack because not only do you get it, you can give that heart attack to a whole lot of other people. And so this vaccination can prevent all of those things. It can prevent spread. It can prevent serious disease. It can prevent you from ever getting it. And so, when I looked at this, I honestly did not believe it until I looked into it a little bit further, that getting COVID-19 is as bad in many cases as having an ST elevation myocardial infarction.
That was excellent, Dr. O'Neill and Dr. Thomas. And just to remind everyone, if you have questions, make sure you put that in the Q&A section. And before we move on to the treatment section, maybe I'll ask Drs. O'Neill and Dr. Thomas one question. Are there any other important outcomes that you think patients in clinic and patients in the emergency department who you're going to discharge home, that's the outpatients are the ones we're focused on here now, are there other important outcomes other than dying from COVID? Like, for example, can COVID cause other things that may significantly impact the life of a patient who's an outpatient in the clinic or in the emergency department? And will vaccination potentially prevent those complications?
Dave, I think it's an unbelievably great question. I think we focus a tremendous amount about mortality, hospitalization in this disease. And one of the things we're learning in the outpatient world is there's a difference between life and living. The patients who become sick with COVID gather a series of events that can impact how they live. Primarily, number one, we think about the ability for chronic dyspnea or long COVID syndrome, clearly something well described now. When we think about the organs impacted by that, we think about two that are really impactful for living. So if I'm a person who comes to the outpatient, I'm worried about what happens with me if I do get COVID and living, I think about what my cognitive ability is. We know that there's now developing data that cognitive ability can be reduced and decline, even in patients who never presented and who are in the hospital. And we also know that the chronic shortness of breath and a syndrome similar to POTS exists, where patients are chronically fatigued and chronically lethargic. So when I contemplate the ability to reduce that in a patient, everyone I know who is our age and between the ages of 40 to 60 thinks about their young children. They think about interacting with them, playing with them. And it is clear that preventing disease acquisition naturally and using vaccination has an impact, at least it looks like, on the development of those secondary symptoms. And so if I'm able to reduce my risk to not live and be alive, that's a win-win for me. And so I think it's something we talk to our patients about as it relates to how their shortness of breath would be. Breathlessness, dyspnea is the most two consistent things that I would be concerned about as a person.
Yeah, and I think that there's another, issue that comes up frequently that's along those same lines is, and specifically with regard to vaccination, I have a lot of my patients, especially my outpatients, ask me, well, I don't want the vaccination because of this feared risk of consequence of there things like myocarditis. They hear about things like thrombosis and stroke, and I have to remind them that all of those risks, all of those things happen with the disease too. It's not just the vaccine. In fact, they happen at much higher rates with actual infection than they do with the vaccine. So I can give you the example of myocarditis that we've heard a lot about. The rates of myocarditis are highest in with vaccination and with viral infections. All vaccinations, not just this one, and all viral infections, not just SARS-CoV-2, but they're highest in men between the ages of about 16 and 22. So that tends to be the demographic with the highest rates of myocarditis. And so I've seen some athletes that have said, they don't want it because they're concerned about this risk. Well, we have great data from the Big Ten that actually looked at cardiac MRI in all of their athletes that were ultimately infected with COVID back last year. And they measured those rates in the cases per thousand, okay? We measure rates of myocarditis with the vaccine in cases per million. So there's about 1,000-fold increased risk of myocarditis with the actual infection than there is with the vaccination. So even though there's risk there, nobody will tell you that there's no risk. You are greatly reducing that risk by going down the rate of vaccination. The same can be true, or the same can be said of things like thrombosis and stroke and things like that we also see. We have seen many people recover and discharge many people from the hospital and from the emergency department only to show up a week or 2 weeks later with a devastating stroke. And those patients don't die. But they do have tremendous and really devastating neurologic disability from these things.
Yes, that was wonderful. Thank you. And as everyone knows, it is now officially gumbo season. And what's the point of gumbo if you can't smell and taste it? So in the next 15 or 20 minutes or so, we're going to move into the meat of this presentation, which hopefully will be very useful for all of the audience members. And again, this will be provided to you separately, so don't worry about taking notes or anything like that. You'll have these materials separately that you can use on a daily basis. And now we're going to start drilling down on how to treat the patient who's in your clinic or is in the emergency department and you're getting ready to discharge that patient to home, how to treat that patient with COVID-19. And one of the most elegant and all, quote unquote, all in one place treatment algorithms that I've seen is this one that we're going to show you next, that was developed again by Drs. Thomas, O'Neill, and others at Franciscan Ministries. And with that, I'm going to let Dr. Thomas take us through this outpatient treatment algorithm.
Thanks, Dave. I would be remiss if I did not thank Emily Johnston, who is our clinical pharmacist, John Bruckhaus, Elena DeKirkelon, who are part of the members of the COVID task force for FMLHS, who the process of creating these documents is essentially a weekly evaluation of the data. And then what we were asked by our audience, essentially of our primary care providers in our emergency, is to try to distill down this 30-page guidance document into something that they felt was useful. And so how we approached this was more on a timeline, on a patient-centered evaluation. And if I was the patient and I put myself into this timeline, an outpatient, and then as we move past outpatient into a potential urgent care ED presentation, what do those look like? Thankfully, over the last probably 5 months, the literature has significantly improved in terms of randomized control trials as it relates to the outpatient arena. The majority of the original data was centered in the inpatient arena. So your patient is one, if we go to the top left-hand corner, who presents with an associated complex of symptoms at a time when prevalence is high. And within that, what we have is COVID-19 and symptoms that range for those patients from mild to severe. We've heard classically about fevers, chills, the typical viral prodromes. Early when we were in alpha beta season, we would talk more about loss of taste and smell, still present, but seemed to be a feature that was most consistent earlier and maybe has a little bit of a drop in the overall incidence. What really came up when Delta started to surge were these other kind of diagnostic or clinical symptoms that presented from a diagnosis perspective. And those were things like headache and nasal congestion. We live in Louisiana, allergy season. We have other kind of things in our wheelhouse that we go, well, this at this point of year in this patient is possibly just an allergic rhinitis, is something they've had consistently. But as the amount of Delta spread and as the infectivity spread, I think what all of us have demonstrated is the patient who presents with that, independent of history of atopy or others, has the possibility that they've acquired the COVID-19 in terms of the Delta infection. And when you take those patients and you think about them, what we need to do is be diligent about consistent testing. Because when you think about treatment requires a diagnosis. And so what I would say is that this constellation of symptoms for our outpatient providers, and when we think about them, requires us to know if they do or do not have the disease. The concerning and troubling signs of symptoms that may present the patient to be more likely to show up to the emergency department appear to be consistent within the outpatient literature. And those are patients who have changes in mental status, delirium, those who have persistent chest pain. We know that Delta strain has a significant amount of pleuritic component as well. So those are the patients who likely have a higher viral potential and maybe more on the spectrum. And then, of course, dyspnea. Dyspnea with or without hypoxia, depending on the way they're presenting. We also tend to see people with more tachypnea while they're febrile, similar to other diseases, and less tachypnea when they're afebrile. And so those are kind of those warning signals, those warning alarms. If you're really getting into the history of the patient, specifically, it's helpful to ask the family if you're able to contact them or the patient themselves about what they are at night, how their morning is, whether their symptoms progress or not. The education in those patients that you diagnose is also critically important. As Dr. O'Neill made, I think, an unbelievably great presentation as related to heart attack. This is a disease that could give another patient a heart attack. And so it's really important to educate the patients with the diagnosis and to do the things we've talked about as it relates to, for themselves, staying home. If they feel like they need a reevaluation, can you set up a process or structure so you can use telemedicine to try to separate and isolate yourself from the others in the household to try to reduce their potential for acquisition, and then to monitor the symptoms, and specifically monitoring those symptoms being dyspnea, significantly, shortness of breath, exercise tolerance. So that's the symptomatology. So now this person shows up in your clinic and you're really in that conversation about, well, is there any evidence-based data that I might have something to provide for the patient? The patient who presents with mild symptoms and tests positive but doesn't require an evaluation in the ER, that's where we've had some difficulty over the last 12 months of what to do. Thankfully, that has gotten better. So you always are going to continue to use supportive measures. Acetaminophen, PRN, ibuprofen has not been demonstrated to be deleterious in the evidence-based literature. So if you have a patient who gets clinical symptomatology that's better with utilization of that medication. And then a lot of concern about underlying nutritional deficiencies. We recommend just a multivitamin daily. Mostly there's not evidence that it improves outcome. There isn't evidence that it changes outcome. There's not evidence that doing that is appropriate. But the constant question about them that comes from the evidence-based literature in other diseases and the association with things that are nutrient deficient allows us just to say taking a multivitamin may not be a bad idea at this point, and eliminates the possibility where people start to take high-dose supplements which are not helpful. If you move past those kind of symptomatology and you say this is a person who doesn't meet high-risk criteria, you ask yourself, is there any evidence-based data? There actually is now. Fluvoxamine is an evidence-based medication that in our guidelines appeared about 5 months ago. It appeared at that point because there was a Stop COVID trial, which came out of Washington University in St. Louis, which was an early phase 2, but a randomized control trial that demonstrated a look at inpatient hospitalization. In that trial, there was a signal about reduction in overall potential progression of symptoms. And so it provided what in evidence-based medicine is the idea for a larger trial. At that point, it moved to a trial called Together, and that's a multi-center adaptive design. And it was recently presented in an NIH collaboratory, and it's about to be published in full. But they gave their data in terms of the overall results. And their results in the Together trial demonstrated symptom reduction and a reduction in hospitalization that was statistically significant in groups that were randomized 700 versus 700, approximately in each arm. So with that, our task force decided there was enough high-level evidence-based data in a patient who presented who did not have a contraindication for utilization of an SSRI to consider fluvoxamine at 100 milligrams PO BID times 10 days. What you have to be really concerned about, though, or consideration in the outpatient arena is, do they have another concomitant high risk that may interact with this medication? So you have to be consistent. Are they already on an SSRI? Do they have a medication that would put them at risk for serotonin syndrome? And then, obviously, patients in the interaction who are on warfarin, given the impact on INR. After that as well, you go, well, that's an oral medication, looks to have what I think would be a patient-centered outcome, reduction in hospitalization. Are there any other therapies? Inhalationally, from a pulmonary perspective, we've started to generate some data as well. And so budesonide have moved into the arena of evidence-based literature with the STOIC trial. The STOIC trial looked at reduction as well in clinical symptoms. So this is a symptom reduction endpoint. And then was followed up here in September with a trial that's called Principle. And again, another large, really well-vetted platform design here in COVID management. Those two together indicate that the utilization of inhaled budesonide may have a patient-centered outcome that definitely demonstrates consistently both a reduction in symptom time. In the Principle trial, there's also a not statistically significant, this is a Bayesian analysis, but it is highly likely that it also presents ED visits potentially and seeking an elevation in care. So when you think about it to the patient level, I'm getting sicker, the data says, hey, there's something consistent here that might be available. What you have to know about that is as an inhaled corticosteroid, and so you should be also advocating for your patient to use or gargle with mouthwash after the utilization of it daily because there's a risk of thrush. Now let's move from those patients who aren't really high risk. And so these are the young patients who come in, no really concomitant secondary medical diseases, don't have COPD, are not morbidly obese, or rather don't have stage 2 or stage 3 obesity. So they don't meet the clinical high risk criteria. In patients who are high risk, who have the potential for clinical deterioration, particularly those who have made the personal decision to remain unvaccinated at the current time, there are risk factors that are well established in terms of decline. In those treatment algorithm, you start to say, let me look at you and in my mind, try to think about what your risk is. Earlier presentation is better. So 1 to 3 days in is better than 7 to 10 days in from the time of symptom development to your diagnosis. So again, to your outpatients, you say, please call me. Let's have a conversation if you believe that you've gotten the virus. In those general risk factors, you have things like pregnancy, age, always comorbidities and ICU level patients and all kinds of severity of illness scoring. And then specifically, we look at the immunosuppressed patients, those who can't mount an appropriate antibody response to exposure to the virus, or those who were vaccinated before who may be at more high risk to not have a robust underlying immunity related to the vaccination that they got. So there you're talking about solid organ transplants, HIV infection with a low CD4 count, and then sickle cell disease. And then if you move into the more chronic diseases, I have these patients in my clinic, I have a chronic disease management, we're in the area of population health, who as well would be in this category. It's those chronic hypertensives who then have secondary cardiovascular disease. Concomitant with that is the diabetics. And then for us in the pulmonary world, we think about patients who have chronic respiratory disease, whether it's asthma, COPD, or some oxygen-containing disease like bronchiectasis or other rare diseases, and say that would be a challenge. The last one here, which I think is interesting, is the neurodevelopment disorders or neuromuscular diseases, because those patients overall, as they progress when they get viral, particularly with COVID-19, tend to have increased myopathies and more progressive symptoms. And so you want to be really aggressive about them. And then finally, it's those patients in your clinic who you are treating aggressively for some other disease, and you are already immunosuppressing them so that their ability to respond to the presence of the virus is mitigated and less. And so those are patients who have had chemotherapy in the past year, who have some autoimmune disease, or who already are on steroids, which would inhibit their ability. Those are the patients that monoclonal antibody administration appears to have the best data, right? So we're talking about best data, not only data, but best data. And so these are the patients that we think about in referring them for monoclonal antibody administration. So if you move over one to the right, it's those high risk criteria. And then you look locally in Louisiana of who is available. Right now at current pace, we have 2 opportunities for medications. We've been thankful enough from partners at LDH, partners in the national government who have looked at the sensitivity to our prior monoclonal antibody, which we here affectionately call BAM plus E because of my inability to say monoclonal antibody names. Right now you've heard about REGEN-COV, which is obviously the first one up top is our first line here for us at FMLHS, which is the carivimab and endivimab. These are 2 infusional agents that have been demonstrated to have a reduction in hospitalization for patients. And so when you think about what Dr. O'Neill was talking about in the incidence of the patients who present, and how do you prevent them from getting to the emergency department for acquiring that 3% mortality risk, this appears to be an evidence-based intervention that can help our patients. And so we're advocating for use. On the opposite side of this, when your patients come to your clinic and they talk about this as something that would be available instead of the vaccination, what I would be very clear in telling them is that these medications, while look to be beneficial and are in an evidence-based perspective, also carry risk. And the risk with them is 2. One is there is a small risk of anaphylaxis that we've been monitoring and watching. Very low incidence, but still not nothing anytime you infuse an antibody. And then the other conversation about when you give a new medication that's under an emergency use authorization, we don't have long-term safety data here. So the one thing we do have long-term safety data on is the FDA-approved intervention, which is the vaccination. This is still under an emergency use authorization in the United States. If I then move from that as the outpatient, then to your person who calls you and says, Doc, I'm just not doing well, I'm going to go to the urgent care, then you move up to the top of this graph. So this is the person who presents to the ED, who does not meet criteria for admission, but has an oxygenation between 88 to 92%. That would put them in the recovery trial group who got steroids, and so less than 92%. And you would consider in this patient dexamethasone 6 milligrams. Let me be very clear. In the other group of patients to the left of this, they should not receive steroids, because if they receive steroids early, they actually put themselves straight into this group down here of high risk, who are unable to mount an immune response and antibody response. So they need a clinical sequelae related to the disease that has impacted their AA gradient and has required them to need oxygen. In the evidence-based literature, that's less than 92% on presentation. And then after that, we move on to the patients who need to be admitted to the hospital because of the tempo of worsening oxygenation, and as a result, they're admitted. And those are the group we're going to talk about next week at the same time in the same evidence-based format of how we evaluate them overall. So hopefully that was helpful to all involved. And this is the way that we've been discussing it. This is a dynamic, changing topic. There's new data every week, but at current pace, we feel like this is the best evidence-based literature in terms of what the potential therapeutics are in the outpatient and how you could handle them in conversation.
That was wonderful. That was as good as this helpful guidance is. This one pager I can speak to this one pager. I've used this since seeing this. I've looked at this about once a week when someone asks me about some guidance on how to take care of an outpatient with COVID. This is incredibly helpful. We have a couple minutes left in this section, so I'll ask Dr. Thomas a couple questions. A reminder, if folks in the audience have questions, to type them in the Q&A. But one question I had for Dr. Thomas was, if a patient presents to the emergency department, they're healthy, they don't have any of those high risk factors, they don't need to be admitted to the hospital, so they're not going to get monoclonal antibodies, they're not going to get dexamethasone because their oxygen saturation is above 92%. Do you treat that patient in the emergency department just like you treat a similar patient who presented to the clinic? In other words, are your options there fluvoxamine and or budesonide?
Yeah, I think it's a great question. I would treat that patient as someone who had the opportunity to go see their outpatient, instead sought initial treatment in an emergency department for some reason. We've seen this more in the pandemic, where maybe the opportunity to see your primary care is. And so I would have a shared decision-making role with them. The one thing I would tell you is that you have to be diligent in the emergency department about their outpatient medications. We have a little bit better access sometimes if it's your own doctor in the outpatient arena. So I think both are an opportunity for prescription. If in a shared decision making that patient says, yeah, that's something that I would want to do, once you talk about the risks for each of those. And so I don't think I would treat those differently, Dave. I think what is really critical, though, is to get that medication administration record of their outpatient medicines to make sure that you're not dealing with any of the interactions as it relates to an SSRI.
There's a question in the Q&A from one of the audience members who's asking, specifically in clinic settings out in the community, is there something that can be done in those clinic settings to help decrease the stress and workload on our emergency departments around the state?
Yeah, I think we've talked about this really consistently from a quality and patient safety perspective here within the system. I think the more you can reach out to your patients, particularly your unvaccinated group on the outpatient arena, and try to have an iterative conversation that says, let's have a conversation about the vaccination. And if you're not able to bridge that gap, telling them, I want you to call me when you think you have symptoms so that I can diagnose you early, I think is really helpful from an outpatient perspective. I think some of the patients feel trepidation in calling their general providers for some reason or another. And so I also think increasing the access to telemedicine or others to make it easier is one thing. Those are the two major kind of process measures that I would take from a clinic perspective to try to facilitate a presentation, a lack of presentation in the ER, and then making sure that your patients at all times for all of their diseases know that you're the first stop because you have the best information and you know them, and to welcome them from a call, I think is the best way to go about that.
Last question from the audience here is a big combination question in that, do you ever combine any of these therapies? Like, for example, do you ever combine both monoclonal and dexamethasone? Do you ever combine fluvoxamine and budesonide? Another part of this question is, do you anticipate any shortages in the monoclonal antibody in Louisiana?
So let me handle the evidence-based part first. In the trials that are outpatient trials, there is no current trial for combination. I will tell you, Together is doing a +1. So looking at adding one medicine that looks to have an impact plus another. I can tell you that I would not be averse personally to the combination of an SSRI plus an inhaled corticosteroid. I think they're different. You can think about those in terms of people that have chronic asthma who as well have an underlying disease. So from a medication administration perspective, no evidence-based data in combination is better than one alone, but I would not be averse to that, particularly if the patient had a significant amount of pulmonary disease or cough. When you start to move into the dexamethasone one, that's a really narrow population in the outpatient who actually gets Decadron, right? It's really that person who shows up 88 to 92. And so in that patient, I would tell you they're closer to being admitted. So I would maybe think about that patient in the Decadron, and then I'm going to call them the next day. We're going to have a follow-up. We're going to think about pulse oximetry, and an outpatient is a very narrow window overall. And then I'll defer to Dr. Cantor about the availability of monoclonal antibodies. We've had some changes here recently. Still are able to really provide it as much as possible, but he is on the pulse here nationally about that supply chain. And so, Dr. Cantor, I'll punt that one to you if okay.
Yeah, it's getting a little bit tighter, unfortunately. I think we're still going to be okay. So up until 2 weeks ago, there was no shortage issues with monoclonals nationally at all. But as Delta is moving its way up north and out west, I think the feds are trying to make sure they have enough stock for the rest of the country. So we're seeing about a 30% cut in monoclonals across the board. That's the bad news. The good news is that bamlanivimab, the Eli Lilly product, is now back on the table because our resistance to it has dropped below 5%. It really was P1, the Brazilian variant, that was the issue with it. So now we have two. We have Regeneron and the Eli Lilly, the bamlanivimab product. I think there's enough. I think we haven't had any real cuts yet. In the coming weeks, it might get a little bit tighter if we get cut more, but so far we've been okay. So the access is still pretty good.
Looks like there's one more question that somebody's asking when we could start colchicine, and I think that colchicine is a reasonable thing to do if for some reason the patient cannot get fluvoxamine. I think that if there's a contraindication for fluvoxamine, it's not available. I think at that point, then colchicine is probably a reasonable thing to do. The Col-Corona study did have some efficacy endpoint there, and it is an RCT. Now it is a 30-day course, so it's a little bit of a longer course, and colchicine certainly has some side effects associated with it, so there needs to be some monitoring there.
Outstanding discussion. And with the final 10 minutes here, we're going to change it up just a little bit, where Dr. Krishnan and I are going to give a few minutes on how to respond to requests for non-beneficial interventions. Like I mentioned at the beginning of this seminar, not only have the therapeutics for COVID become increasingly complex and where you have to know there's some new information coming out every day, but also, again, the general public is now fascinated in this topic of how to prevent and treat COVID. And now anyone who can Google something or anyone who can tweet or make a YouTube video now all of a sudden is involved in deciding what's the correct way to treat a patient with COVID. And what comes up commonly is you have patients and families who are asking you for things that have not been shown to have any benefit in preventing and treating COVID. And so this is going to be a little bit different, but first, this session, but first, let's go through the background here in regards to how to respond to requests for non-beneficial interventions. And it begins with something that you all learned in medical school, the principles of medical ethics, the 4 pillars back then of medical ethics: autonomy, beneficence, non-maleficence, and justice. And recently, the proposed added 5th pillar of medical ethics, parsimony, based on trying to avoid wasteful care. And really, when we're talking about patients or families that are asking you for therapy, which in your expert opinion has no benefit towards that patient, we are narrowing in on specifically this principle of medical ethics, the non-maleficence principle, or also known as the do no harm principle. The do no harm principle of medical ethics, everyone is as commonly thought of that as, oh, that's the easy one, right? It's the easy one to remember. Don't harm patients. Don't actively do something to hurt a patient. I get it. I'm with you. I won't actively harm a patient. Everyone's on the same page about that, but what sometimes people forget is this principle of medical ethics not only involves don't actively harm a patient, it also involves protecting your patients from things that have no benefit and only the potential risk of harm. In other words, the do no harm principle of medical ethics includes avoiding this scenario, giving patients something that has no health benefits, there's no evidence that it will benefit that patient anyway, and only exposing them to side effects. That is a bad scenario. If you look in the medical ethics literature over the past couple of decades, the most common example of this scenario that's come up pre-COVID has been someone, a healthy 25-year-old, CEO of a company who is more rich than you can ever imagine, says the way I want to be kept healthy is I want yearly whole body MRIs and I'll pay for it. I know there isn't any evidence to support it, but I want to buy yearly whole body MRIs just because I think that's going to help. To do that for that patient would be unethical, because there is no evidence that that actually would improve that patient's health, and it only exposes that patient to the side effects. Here, the side effects being misdiagnosis. COVID is no different. There's plenty of interventions that have been studied and discussed in COVID that have this similar bad equation that you see on the screen of no health benefits and only exposes patients to side effects. Beyond the ethical principles here, there's only so much time in a day. There's only so much pie, as they say. And you can either spend the time of your day in performing high value care for your patients with very little time of your day spent performing low value care. Or if you let those low value things seep into your day, there's only so much pie. If you spend a bunch of time on things that don't help a patient, you will spend less time on things that we're pretty convinced helps patients. So what shouldn't you spend time on in the treatment of COVID-19? These things that you see on the screen. These things have been studied in some regard and don't have any high level of evidence that they actually will help a patient with COVID-19. If you spend a bunch of time on this stuff on the screen, it's not going to help your patient, and it's only going to distract you from the things that do help patients, things like this that you see on the screen here, things that would be considered high value care. So we've talked a little bit about corticosteroids so far, and then supportive care, especially in patients in the intensive care unit that we're going to get to next week. Which brings us to the next question is, well, now you have a patient or their family in front of you that needs to be treated. They're in your clinic or they're in the ED with you. They need to be treated for their COVID. And the question is, what's the process on how to work with that patient or their family member in making a decision of what should we do to treat the patient? And I'm going to let Dr. Krishnan go through this particular process.
Yeah, thanks. So definitely what you just said, the interventions and treatments that you provide your clinic patient really should be based on this shared decision-making model. And so this model includes both the best scientific evidence that the doctor will bring to the discussion, like information about diagnosis, treatment, prognosis, and then there's the patient's values, goals, and preferences that the patient will bring to the discussion. So you need both aspects, and this comes into play when talking about treatments for COVID. So the steps to shared decision making: first, you want to develop a relationship with your patient, kind of the first three on the list. Establish a partnership, provide emotional support, assess understanding. And then next, you really want to explain the patient's diagnosis of COVID-19 and the treatment options based on the best scientific evidence. And then ultimately, you both discuss the patient's goals and deliberate as to what the best decision for that patient would be. And so Dr. Jans and I, we want to act out a scenario using this shared decision-making process to demonstrate the major steps here, but we're really going to focus on explaining the medical situation and explaining reasonable treatment choices. So Dr. Jans is going to be our patient.
Okay. So I'm a young, healthy patient with no high risk factors for complications from COVID, like Dr. Thomas discussed. I'm in Dr. Krishnan's clinic, and I tell Dr. Krishnan all this. I feel lousy. I have a headache. I have a little bit of chest pain, but I'm otherwise well. Doc, how do you want to treat me?
Well, first off, I'm really sorry you're feeling badly, but since you don't have any serious risk factors, we can consider fluvoxamine 100 milligrams twice a day, or an inhaler like budesonide, or depending on what you want to do, we can always watch and wait and see how things go.
Okay, I'm actually already on sertraline as an outpatient. Maybe I'll choose to use budesonide instead. Is that okay with you?
Yeah, I think that sounds great. So since we don't want you on an SSRI and fluvoxamine at the same time.
Good. So that's just a brief example of what we're talking about here, of how you can go through this process. What to point out here with what Dr. Krishnan did, one of the most important things to point out is notice that she didn't offer me a buffet of things. She offered me things that have evidence to support them, not here's a list of a dozen different things that have little or no evidence to support them. You pick. She provide her expert opinion. I provide my values based on what my outpatient meds are, and we came up with a decision. That's how it's supposed to work. Now let's get into this stickier subject, which I'm young. I don't remember the last time the Louisiana Department of Health put out something specifically saying don't use this drug. It's a new one for me, but it's official guidance from the Louisiana Department of Health in regards to this specific drug, ivermectin, and for good reason. There's guidance, and so let's go through three scenarios here. Three common scenarios that a patient or their family may ask you, the doctor, for a low or no value intervention, specifically in this scenario, ivermectin. And first, here again, I'm the patient. Dr. Krishnan is my clinic doctor. And I say something like, I heard someone talking about it, but don't know anything about the medication. Do you think I should take this?
So ivermectin is usually used to treat parasitic worms. The science doesn't suggest that this treatment is safe or effective for COVID-19. And so I don't think we should use this medication to treat your illness. The risks really do outweigh the benefits in this case.
Great. So just to remind everyone, if someone's asking you for ivermectin, it doesn't mean that they're a bad person or anything. They may have just heard of it and they want to know something about it. They're not a conspiracy theorist who's looking for some specific answer. They just may want a little education, and that's good. That's all they need. And then you move on to more reasonable things. Second scenario, we'll take it one step up here, where I tell Dr. Krishnan, I've actually researched this intervention, and this doesn't just apply to ivermectin, but I've actually researched this on Google, for example, and it sounds promising. And I want to know if Dr. Krishnan will prescribe this for me.
Yeah, so there have been many studies looking at ivermectin in COVID, and the vast majority of them don't help patients. The few papers that suggest ivermectin may help, the data in those studies was actually found to be incorrect. So there really isn't any scientific evidence that ivermectin works, and therefore I don't recommend using this for your COVID infection.
Great. So there she's taken it one step up. The patient has taken the time to learn something via some format about this intervention, and she's meeting the patient on that same level to try to educate the patient about it. The last scenario, which is fortunately less common, but unfortunately usually the more dramatic scenario, where I, the patient, tell Dr. Krishnan, no, I know it works. Doctors are hiding the truth by not prescribing me this, or my mom, and I want my mom to get it here. You need to prescribe me this medication.
Yeah, I'd probably start this scenario with, what I would probably do is start off with, what did you hear or why do you think ivermectin works?
I heard it on YouTube that it works.
Okay. So it's important to remember that there are a lot of studies involving ivermectin that are negative, meaning they do not help patients with COVID. There were a few positive studies, but there was a lot of falsified evidence in those studies, and they've been removed from the literature. I believe ivermectin is harmful and that the risks really do outweigh the benefits.
Yeah, I still don't trust you. I think it would work. I believe the people who told me that it would work, and I want you to prescribe this medication.
So I really do care about your mother, and I really do want her to get the best treatments available. And I do not think ivermectin is a good treatment for your mom.
So are you saying you won't prescribe this medication to my mom?
I will not prescribe ivermectin because there is no medical evidence supporting it. It's not the right thing to do.
Yeah, so that's the end of that scenario. But notice at the end of that scenario, the important part is it's okay to end this conversation by agreeing to disagree. Your duty is to the patient. Your duty is not to agree with whoever's talking to you about whatever intervention they think is right. Your duty is to the patient, and that duty is based on your expertise on how to treat patients. People they can ask for the whole buffet of things, whatever they've learned about, but that doesn't mean that they can get it, because here you're trying to avoid this scenario of interventions that have no health benefits and only expose patients to side effects. That is your duty to the patient. Your duty is not agreement with everyone in the room. You aim for that. That's the nicest scenario. But if that can't be achieved, then it's okay. You're not a bad doctor, a bad advanced practice provider, a bad nurse if you can't achieve agreement all the time. You just have to agree to disagree sometimes, but still remember that your duty is to the patient, not people who are asking you for the buffet of stuff. And with that wraps up this seminar on outpatient treatment. If people can still type in questions in the Q&A, and we'll try to get them answered. I'm going to thank Dr. Cantor and the LDH, and also all the other presenters that were involved in the seminar. And for those interested in inpatient treatment, we will see you back here same time a week from today.